بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. اليوم إن شاء الله نتكلم على موضوع مهم ودايما بنقابله في حالات لو أنت في تيرشري هوسبيتال طبعا بتشوف الموضوع ده في الاستشارات دايما مع حالات في قسم الأورام أيا كان المكان اللي أنت فيه، خاصة لو مستشفى تيرشري وكده يكون عندك قسم أو جزء في المستشفى من متخصص بقسم الأورام أو المرضى السرطان، عافانا الله وعافاكم جميعا. اليوم هنتكلم إيه اللي أنت عايزه بالظبط، عايز تعرفه بالظبط في الأونكونفرولوجي لما تشوف حالة استشارة للنفرولوجي عن for AKI أو CKD whatever or high creatinine with patient with cancer after discovered during his just his course of treatment or before treatment or after any contrast. We'll see all scenarios will happen during the nephrology course for our patient. The Onco-Nephrology today will talk today what you need to know for Onco-Nephrology. بسم الله الرحمن الرحيم. قال سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. بسم الله الرحمن الرحيم. توكلنا على الله. Why Onco-Nephrology? This is the first question you should ask. Why Onco-Nephrology? Onco-Nephrologists help cancer care term, prevent kidney problem or resolve them as they arise and improve the patient outcome. احنا دلوقتي دخل في حاجه اسمها سب سبيشاليتي في النفرولوجي اسمها اونكونفرولوجيست، وده طبعا بدا لما حصل ان الانكولوجي اوريدي كانوا بيتابعوا العيانين في الاول، وكان بينتهي معظم العيانين بينتهوا بدياليسيس او بينتهوا بسكي دي deterioration or progressive deterioration of the patient kidney function. فبدا يستعينوا بالنفرولوجي في النقطه دي بالذات، هم يركزوا في المانجمنت بتاع البرايمري ديزيز، والنفرولوجي بيتابع الكدني فانكشن وات ايفر the different scenario we'll see now whatever, because we have already pre-renal, renal and post-renal AKI, and now this job of onco-nephrologist in our tertiary hospital here. Any patient with AKI recently should be seen by nephrologist, and the nephrology will follow everything from electrolyte, acid base, AKI, CKD, GN, whatever the cause of his kidney problem. A more focused approach to cancer nephrology may also help address a challenge like renal carcinoma and end-stage renal disease. We'll see now what is the onco-nephrology. The onco-nephrology, as I said for you, is dealing with the patient before or after he ended by CKD. We'll start from acute kidney injury, whatever the cause, from the start of diagnosis of the disease and before chemotherapy and before any radiology and before any chemotherapy for the patient. I will start to see the patient from AKI, and this AKI may be, as we said for you, maybe pre-renal, renal, and post-renal, and all this should be classified during the first visit for our patient. Maybe cancer specific, maybe some tumors also lead to this progression of his AKI and ended by CKD also, with paraneoplastic syndrome, hypercalcemia, tumor infiltration of the kidneys, urinary obstruction, like obstructive uropathy, and the glomerular disease associated with either primary disease or chemotherapy, and we'll discuss all this by details. We have cancer therapy factors, we have anti-neoplastic agent and the anti-cancer target therapy and the tumor lysis therapy and immunosuppression, nephrectomy, radiation, all this and other therapies, all this we'll discuss in details by cases. And patient-specific factor like age of the patient, elderly patient already with low GFR and other diabetes and hypertension, all this risk factor to end by your patient to be CKD and end-stage renal disease and need dialysis in future. Timeline of birth and the growth of onco-nephrology. Onco-nephrology just started to be appear, I think, issued already started in 2010, and then started to progress at 2011, 14, and till now, and 21, and started to be increase and to grow and to involve in nephrology in any oncology patient, because when after oncologists show just sharing the cases with the nephrology will end by good outcome for the oncology patient, before the patient go to interstitial disease, and many patients treated before and return to normal function when referred to nephrology, and comparison before, and we'll discuss this also in details. Why do we need an onco-nephrology? Onco-nephrology, kidney diseases are frequent and increasing complication of cancer, either cancer itself or medication, whatever. There is bi-directional relationship between the cancer and the kidney disease. Onco-nephrology is a growing area of nephrology that require clinicians to have a better understanding of renal complication of cancer, including electrolyte, acid base, AKI, and CKD. So is now started the onco-nephrology taking care of this AKI, CKD, acid base electrolyte, any cancer patient, either before therapy or after, during the therapy or after the therapy. What I mean chemotherapy. As we know, this relation between cancer and AKI and the CKD, as we see in our slide, cancer and AKI and CKD are linked by various exposure and pathways that either related to paraneoplastic kidney injury, toxins, and nephrotoxin medication like chemotherapies, radiation, and nephrectomy. When any patient with diffused cancer in his kidney and need nephrectomy, and after that radiation, uremic and CKD, uremic symptoms and CKD, and independent by interstitial disease, even transplant, after bone marrow transplant, whatever, or kidney transplant. All this will end by AKI, CKD, and will end it. All this will end by interstitial disease and hemodialysis if we will not manage this patient from the start point. And this is a relation between this cancer and AKI and CKD. Everyone lead to other, especially cancer by his bile disease itself or bile chemotherapy will end precipitate AKI and will end by CKD, interstitial disease, and the hemodialysis or kidney transplant. Approach to patient with monoclonal gammopathy. This is the main topic today. I need to concentrate how to investigate any patient came by proteinuria, whatever, or AKI, or a patient with picture, just to give you some symptoms like suspect you are maybe multiple myeloma. Then we need to know now how to read the test and how to order the test. What's your approach to this patient? Approach to patient with monoclonal gammopathy is the main our topic today. What is the definition of monoclonal gammopathy? How do patient with monoclonal gammopathy is present? Care of patient with monoclonal gammopathy also. We'll discuss all this in our presentation today. Monoclonal gammopathy already around 60% of our patient, as we'll see our patient in oncology, around 60% will be megas. This is monoclonal gammopathy of unspecific or undetermined significant. Multiple myeloma around 20% after that. Monoclonal gammopathy maybe will end by all the other types. This is the first starting point of this multiple myeloma and other amyloidosis and other. With the main diagnosis, most around 60% of oncology patient will be diagnosed as megas. This monoclonal gammopathy of unspecific or undetermined significant. From this megas already, some patient will go if with good follow-up. Around 20% will end by multiple myeloma, and other around 10% will end by illa amyloidosis, and the other lymphoproliferative diseases, and the other smoldering myeloma around 4%, solitary or extra medullary around 2%, macro gamma globulinemia already around 2.5%, and others around 4%. This our diagnosis here will be megas. This patient need frequent follow-up before he will end it by this categories of different disease. This monoclonal gammopathy, the presence of excessive amount of immunoglobulin in serum, either IgG, IgA, IgM, DE. Like when you can see this MAGID or just to keep MAGID or JAMID. Just to remember this, all this for heavy chains, and we have free light chains, either lambda or kappa. All this under this monoclonal gammopathy. All this immunoglobulin already will found in the serum, and we'll discuss this my target today to understand how you can request or to investigate for this disease in oncology patient. depending on the nature of monoclonal gammopathy, patient may be present with range of condition, either asymptomatic, incidentally discovered, or critically ill with multi-organ system dysfunction, and we'll discuss this. Either our patient just incidentally discovered, asymptomatic, or critically ill with multi-organ dysfunction. Monoclonal gammopathy is a hallmark of plasma cell dyscrasia, and the hallmark of plasma cell dyscrasia and some beta cell lymphoproliferative disorder. Okay, this is a hallmark of this plasma cell dyscrasia. This is monoclonal gammopathy. Plasma cell dyscrasia, as we know, our bone marrow will end by death lymphoid and myeloid cells. Lymphoid cells will end by T cells and B cells, and the B cells will secrete this plasma cells, and the plasma cell will give us this immunoglobulin oral antibodies. And this green one or blue one with the light chain, and this is the heavy brown one is this is the heavy chains. Heavy chain and this light chain. This light chain, this light chain, and this long one is heavy chains. Now, plasma cell dyscrasia means the beta cell will excrete or secrete more plasma cell, and the plasma cell will be activated, overactivated, and will secrete more antibodies or immunoglobulin in our serum. This all antibodies composed of two heavy chains and this light chains. This is a brown one, heavy chains, and this light chain. I need you to understand from this slide, because I need you to don't forget this again, just to listen, and you will not forget again. Plasma cell dyscrasia, this is an issue for multiple myeloma or megas or whatever. This started by beta lymphocytes. The beta lymphocytes will secrete this plasma cell, and the plasma cell will secrete these antibodies, these immunoglobulins. This is compared of heavy chains and the light chains. The light chains is a blue one, and these heavy chains, this is a brown one. As our bone marrow already, just hematopoietic stem cells, pluripotent cells already will ended by this myeloid and lymphoid. Lymphoid ended by T cells and the B cells, and the B cells will ended by plasma cells. This will secrete more antibodies or immunoglobulin in our serum. And this myeloid cells will ended by erythrocyte, platelet, eosinophils, basophils, neutrophils, and monocytes. All this from myeloid cell. يبقى الهيموبويتيك stem cell will ended by myeloid and lymphoid. Myeloid cells is will ended by all other cells. Lymphoid will end by T and B cells. The B cells will ended by plasma cells here. Pluripotent stem cell will ended by lymphoid cells here, as we mentioned, and B cells. Lymphoid cells will ended by T cells, and the B cells, as we said, pre-B cells and mature B cells. This will ended by secrete more plasma cells. Plasma cells will secrete more antibodies. As we see here also, plasma cell dyscrasia equal monoclonal gammopathies equal paraproteinemia equal dysproteinemias. This you just about don't forget this. Paraproteinemia means plasma cell dyscrasia or monoclonal gammopathy. Paraproteinemia now, يبقى plasma cell dyscrasia. Either monoclonal gammopathy, either paraproteinemia, either dysproteinemia. Plasma cell dyscrasia, monoclonal gammopathy, paraproteinemia, dysproteinemia, all same names. We have here normally beta cells or beta lymphocytes will secrete the plasma cells. Plasma cell will secrete this antibodies or immunoglobulins or gamma globulins. This compare of light chains and the heavy chains. The light chains is the blue one. This is the blue one here. This is the blue one. This light chains, and this is the heavy chains. We have 5 heavy chains isotypes. مين اللي هم مجدي، ممكن تسموهم يا اما مجدي يا اما جامد as you like عشان ما تنساش. اللي هم ام اي جي جي ام اي جي اي دي. اوكي، ممكن تسموهم جامد او مجدي زي ما انت عايز تسميهم، زي اي اسم انت هم تفتكر ان هم 5 موجودين عندك، اللي هم الهيفي تشينز. دول اللي هم الايزوتايبس بتوع الهيفي تشينز، اللي هم مين؟ اللي هم دول اللي انت شايفهم ده بتوع مين؟ الجاما جلوبلينز والانتي بوديز او الامينو جلوبلينز اللي بيسموهم جاما جلوبلينز. بيتكونوا من 5 هيفي تشينز. ايه هم ال5 اللي هم الاي جي جي ام اي جي اي دي. طب التو لايت تشين كابا ولامدا، ما عنديش الا كابا ولامدا، يبقى تو لايت تشينز هنا اللي هم كابا ولامدا. يعني ايه هنقول ايه؟ لو انت سميتهم جامد، جامد هي هيفي خليها من جامد، جامد يبقى هي جي و اي و اي ام دي جامد هيفي. طب اللايت اللي خلى اللامدا اللايت يعني خفيف، خليها مش منور يعني، خليها لايت يعني خفيف. هيبقى عندك لايت اللي هي اللمبه والكابه والغطاء بتاع اللمبه، يبقى اللمبه والكابه. يبقى احنا عندنا تو لايت تشين لامدا وكابه، وتو هيفي تشينز اللي هم بنختصرهم في جامد. تمام. انا عايزك ما تنساش الحته دي تماما، لان دي بدايه ان انت تفهم موضوع الانكولوجي كله بما فيه المالتيبل مايلوما والقصص دي كلها عشان تنهي الصداع بتاع الموضوع ده. يبقى احنا بدانا بالبيتا ليمفوسايتس. احنا قلنا البون مارو هيطلع ايه؟ هيطلع ليمفويد ومايلويد. الليمفويد بتطلع لك بيتا سيل واللي ايه؟ وتي سيلز، والمايلويد بتطلع لك باقي الخلايا كلها، ريد بلاد سيلز والوايت بلاد سيلز بانواعها الثانيه. خلينا في الليمفويد. الليمفويد قلنا بيتا سيل وتي سيلز. البيتا سيل بتطلع لك البلازما سيلز. البلازما سيل بتفرز لك مين؟ بتسكريت الانتي بوديز اللي هو اسمه جاما جلوبلينز. طب الجاما الانتي بوديز او الامينو جلوبلينز او الجاما جلوبلينز ده بيتكون من ايه؟ تو هيفي تشين. هيفي يعني تقيل او جامد، فهو جامد. ده الامينو جلوبلين مكوناته من خمسه هيفي تشينز ايزوتايبس. تمام. اللايت عشان هو خفيف وحلو كده، فالتو لايتس هو حتى هو تو لامدا وكابا. اللامبا خليها في اللامبا والكابا الغطاء بتاع اللامبا من فوق مثلا. تمام كده. عايزك ما تنساش الحته دي. In most plasma cells light chain are sensitized in excess. Free light chain. تمام. and cleared by the kidney. most plasma cells. الخلايا ديت البلازما سيلز بتطلع لايت تشينز بكميه كبيره. but normally المفروض انها تكون اقل من 10 جرام بير داي. normally less than 10 جرام بير داي. more than 10 جرام بير داي دي اسمها بنس جونز بروتين. دي اللي بنشوفها في اليورين. لما بتضرب بيبي يورين بروتين الكتروفوريسيس تلاقي بنس جونز بروتين لو اكتر من 10 بيبقى لايت تشينز، لان اللايت تشين بيحصل له ري ابزوربشن وكاتابوليزم رابيدلي ان ذا سيرم. وهنجيب لك الحته دي بتاعت الهاف لايف بتاعت الفري لايت تشينز. تمام. يبقى احنا عندنا اللايت تشين اللي هم اللامدا والكابا بيفرزوا بكميات كبيره وكليرد باي مين؟ بيحصل لهم كليرنس باي الكدني. بات نورمالي ليس ذان 10 مللي جرام بير داي. لو اكتر من 10 مللي جرام بتشوف انت البنسيكونز بروتين في اليورين اللي هو اليورين بروتين الكتروفوريسيس. فري لايت تشينز not detected by urine dipstick. خد بالك لما تلاقي العيان عنده مثلا بروتينيوريا او اي حاجه من الحاجات دي وتعمل ديبستيك، ما تلاقيش تلاقيه نيجاتيف للالبومين، بيبقى نيجاتيف للالبومين. لكن عندك عين بروتينيوريا وكده وما لقيتش الديبست الالبومين بوزيتيف، تفكر في ايه؟ في البارابروتينيميا دلوقتي. بارابروتينيميا، مونوكلونال جاموباسي، ديسبروتينيميا، بلازما سيل ديسكريزي. تفكر في الحته دي. يبقى الديبستيك ده معمول مخصوص للالبومين. ده بيعمل ديتكت القلب. لو انت عندك مثلا نفروتك رينج ولا عندك اي كان النمبر بتاع البروتينيرا في اليورين، لو انت حطيت الديبستيك نيجاتيف للقلب معناه ان في بروتين تاني، ممكن يكون اي نوع من انواع الثانيه دي هيفي لايت تشين، وهنشوفهم في اللي جاي ان شاء الله. you need now for this patient urgent electrophoresis. if البيشنت لقيته نيجاتيف للديبستيك، يعني العين عنده مجمع بروتين في البول مش 24 1.5 جرام 2 جرام 3 جرام 4 جرام، وحطيت ديبستيك نيجاتيف، هلا في بقى بروتين تاني غير الالبومين. دلوقتي تفكر في مين؟ في البارابروتينيمي. تفكر في الانواع دي كلها. تمام. التاني ده كده الهيفي تشينز، الاثنين الكبار الطوال دول، لكن الاثنين القصيرين دول اسمهم لايت تشينز عشان ما ننسوش. طبعا وبينهم داي سلفايد بوند ده اللي ماسكاهم. وفي هنا برضو ديت هنا برضو ايبيتوبس هنا ماسكه في اللايت تشينز مع الهيفي تشينز. دي الكابا مثلا، وديت اللامدا والكلام ده كله. دي كابا لايت تشينز ودي لامدا لايت تشينز. ده بس عشان نفكرك تاني وحتى نفكرك بيهم. ده على بعضه كده اسمه انتاكت اميونوجلوبولين. either immunoglobulin G or A أو D أو whatever أو E. ده على بعضه كده من أوله لآخره، ده على بعضه كده اسمه intact immunoglobulin. تمام. هنا المونوكلونال بروتين produced by البيتا سيل or بالبلازما سيلز. طبعا المونوكلونال بروتينز اللي هو الاميونوجلوبولينز ده بيبروديوسد باي مين؟ بلازما سيل اللي هي جايه من البيتا سيل. It can be complete IgG and light or heavy chains. either from light chains or heavy chains, these immunoglobulins. The detection of this paraprotein in the blood or urine is monoclonal gammopathy. Monoclonal gammopathy can be related or unrelated with malignancy. وهنتكلموا عن الكلام ده كله زي ما قلنا هنا اللايت تشين دي وده الهيفي تشينز. تمام. انا بس حبيت افكرك بقى تاني وهفكرك بيها. each IgG كل immunoglobulin has around 25 kilodaltons. Structure variation may determine the toxicity of an individual of IgG and or free light chains. 40% overproduction of the free light chains ونتكلم عن لحد دلوقتي. normal ratio كاب على اللامدا ريشيو 0.2 ل 1.6 ده في النورمال جي اف ار النورمال كدني فانكشن بيشنت. ده النورمال ريشيو. هنتكلم على الابنورمال ريشيو في النكست سلايد. ودي كاتابلايز باي البروكسيمال تيوبلر ابيثيليال سيلز بيحصل لهم كاتابوليزم باي الكدني رابيدلي. She should be measured rapidly. 1 to 10 milligram as we mentioned before per day in urine. More than this you should think in malignancy. بلازما سيل اند انتي بوديز immunoglobulins زي الاميونوجلوبولين اللي جاي من ايه؟ من البلازما سيل زي ما قلنا البلازما سيل بالشكل بتاعها. ده اللي بيطلع لك الاميونوجلوبولين زي ما قلنا الاميونوجلوبولين عباره عن هيفي تشينز ولايت تشينز تاني. اللايت تشينز اللي هم كابا ولامدا والهيفي تشينز الهيفي اللي هم جامد اللي هم جي واي وام دي اي. لايت تشينز اللي هم اللامدا والكابا. اتمنى تكون الدنيا واضحه. ده اسمه الاميونوجلوبولين. واحنا لما تيجي تعمل يورين او بروتين الكتروفوريسيس او الفري لايت تشينز بيتشخص عندك المريض بتاعك هو ده اسمه مونوجلوبولين مونوكلونال انتي بوديز. فبتقول اي جي جي بتاخد واحد من الهيفي تشينز واحد بيبقى لازم يكون معاه واحد من الهيفي تشين او واحد من اللايت تشينز وساعات بيبقى يا اما لايت تشين لوحده او هيفي تشين لوحده. فاحنا لو خدنا معظم الحالات اللي بتتشخص بنقوله اي جي جي امونوجلوبولين جي اللي هو هيفي تشين جي اللي هنا مثلا لو طلع معانا بالاميونوفيكسيشن وهنتكلموا عليها معاه واحد لامدا زي زر لامدا او كابا اي جي جي كابا او اي جي جي لامدا مونوكلونال جاموباسي. ده اسمه التشخيص النهائي بتاعك. بس هنيجي على الخطوات دي واحده واحده. خليك بس فاكر بلازما سيل بتطلع لك الاميونوجلوبولين. الاميونوجلوبولين عندنا 2 هيفي تشينز 2 لايت تشينز. الهيفي تشينز الثقيله من جامده الجامده دي من جامد. تمام عشان ما ننساش ده الاميونوجلوبولين بتاعها الاي جي جي بتاعها اللي هو جي واي وام دي اي. وعندك اللايت تشينز اللايت خفيفه لامدا اللمبه بتاعتك والكابه الغطاء بتاع اللمبه لامدا وكابه. تمام. وان البلازما سيل دي وظيفتها ايه؟ لما بيجي اي انفكشن بكتيريا او فيروس في البودي هو بيطلع لك ايه؟ الانتي بوديز والاميونوجلوبولين زي ما انت شايف عشان تعمل اتاتش لمين؟ للفيروس او البكتيريا. بس احنا عندنا اللي في النورمال والمايلوما ايه الفرق بينهم؟ ده بيبقى بيليكلونال. شوف مختلفه الشكل واللون مختلفه على حسب البكتيريا والفيروس وكده فبيطلع لك ديفرنت انتي بوديز. ده من مين؟ من البوليكلونال immunoglobulin او بوليكلونال بلازما سيلز. لو عندك مونوكلونال اللي هي 1 سيل انتكت immunoglobulin المايلوما بتبقى 1 سيل وعماله تطلع لك نفس انتي بوديز اللي هو هيفي او لايت ومع بعض اي جي جي كابا ولامدا زي ما يكونوا هنا مع بعض مختلطين بكميات كبيره اوفر برودكتد all antibodies and excess light chains and too many of both. طلع لك ده مايلوما مالجنسي بقى بيبقى عندك سيزف في كل حاجه. انت عندك مونوكلونال مايلوما هنا مونوكلونال يعني 1 سيل بتطلع لك سيم انتي بوديز immunoglobulin. تمام. بلازما سيل ديسكريزيا مونوكلونال جاموباسي مونوكلونال بي سيل ديسكريزيا increase in single immunoglobulin ام كومبوننت اللي هو ده اميونوجلوبولين واحد دي مونوكلونال يبقى خليه هي نفس الخليه مش زي البولوكلونال النورمال لكن ديت مونوكلونال نفس الخليه وعماله تطلع نفس انتي بوديز بكميات كبيره. increase in a single immunoglobulin ام كومبوننت and ام كومبوننت احنا فاهمها ام ديت يعني مونوكلونال and its corresponding light chains or other suppressed. انت فاهم يعني ايه؟ يعني انت عندك دي مونوكلونال هنا اهو مونوكلونال بلازما سيل او مايلوما بيطلع لك انتي بوديز هيفي تشينز ولايت تشينز في نفس الايه بيطلع لك اهو اند اتس كورسبوندينج بيطلع لك المونوجلوبولين اللي هو الهيفي تشينز والكورسبوندينج بتاعه اللايت تشينز اند الاذر ويل بي سبريسد. انت عارف الحته يعني ايه الاذر بي سبريسد؟ يعني انا مثلا لو عندي IgG طلع تمام. يبقى عندك الام والاي والدي والاي كلهم هيحصل لهم سبريس، بس الIgG اللي هيبقى عندك عالي في التحليل تمام. ده معناها الحته دي. فانت لما تلاقي مثلا IgG كابا معناها الIgG هيبقى عالي والكابا هتبقى عالي والباقي كله هيبقى سبريسد ويبقى العيان بتاعك اميونو سبريسد. most of that بيبقى high risk for infection already تمام. That's the cause of infection for this patient. most common infection pneumonia or UTI or pyelonephritis، وهنتكلم عن الكلام ده بالتفصيل في الكيسز. most common is IgG gammopathy. This is the most common type Ig immunoglobulin G gammopathy تمام. That's why patients with monoclonal gammopathy are immunologically suppressed. العيان ده بيبقى عنده immunosuppressed already. البيشنت بتاع المونوكلونال جاموباسي بيبقى suppressed تمام. لان لما يبقى عنده اي جي جي عالي الباقي كله A والام والدي والاي كلهم بيبقوا suppressed تمام. and secrete in urine بنس جونز بروتين كابا ولامدا، دول بتشوفهم في اليورين طبعا. monoclonal gammopathy or of unspecific or undetermined significant unknown etiology عشان تبقى عارف ماليش سبب. pre-malignant clonal plasma cell disorders دي pre-malignant case. when diagnose your patient by megas, when you see any oncology patient and you diagnose as a monoclonal of unspecific or undetermined significant, this unknown etiology with the pre-malignant case need close follow-up with the pre-malignant of clonal plasma cell disorders. M spike, you will see M spike in serum protein electrophoresis and urine protein electrophoresis, and I will show you now what means by M spike. M proteins less than 3 grams per deciliter, and I will show you. And when you do a bone marrow biopsy, plasma cell, clonal plasma cell in the bone marrow less than 10%. This is the criteria for the monoclonal gammopathy of unspecific or undetermined significant. M spike will be present. M protein less than 3 grams per deciliter, and this is the 24-hour protein, and less than 10% clonal plasma cell in the bone marrow by bone marrow biopsy. 1% of the population 50 to 60. The median age already around 70s, but already 1% of the population maybe will found يعني 1 في كل 100 بتشوفهم، و1 في كل 100 برضه بيحصل له transformation each year from this megas to multiple myeloma or amyloidosis, whatever the malignancy will be transformed. And الميل دايما common than الفيميل. الميل دايما common than الفيميل. البلاك more than الوايت. البلاك more than الوايت. والميل أكتر من الفيميل. Why do we care about this megas monoclonal gammopathy of unspecific or undetermined significant? ده because malignant transformation to multiple myeloma, amyloidosis, and other types of malignancy, and we'll discuss this. Megas criteria: no end organ damage, no CRAB, no monoclonal proteins less than 3 grams per deciliter, clonal plasma cells less than 10% of bone marrow biopsy. Treatment: no treatment necessary or needed for megas. Periodic follow-up to detect malignant transformation as early as possible. You should follow CRAB. What means by CRAB? C, hypercalcemia. R, renal impairment. A, hemoglobin drop, anemia. B, bone lytic lesion. This is a CRAB. Calcium high, creatinine high, hemoglobin low, and the serum protein electrophoresis, urine protein electrophoresis, and the free light chain. You should order all these lab tests. And we'll discuss why. Prognosis: megas risk of 1% per year malignant transformation. Multiple myeloma increase risk if M protein more or equal 1.5 grams per deciliter. Abnormal lambda to kappa ratio. Lambda to kappa ratio. And decrease 1 or 2 non-involved IgG. Okay, either IgG-M, DE if IgG is high, the other will be suppressed. If one high, the other should be suppressed. This is the risk for 1 year malignant transformation. 1% means 1 each 100 each year. If the M protein more than 1.5 or equal 1.5 gram, abnormal lambda kappa ratio, this cannot see, and decrease 1 or 2 of non-involved IgG. انت لو عندك الاي جي جي انت شخصت المريض بتاعك اي جي جي كابا اور لامدا وات ايفر or IgG-M lambda, you should see الأذر suppressed, other G والM والA والD والA. لو one يعني one IG immunoglobulin is high, the other should be suppressed. تمام. Megas monoclonal gammopathy of undetermined significant rule of no. اوعى تنسى الحته دي. No malignant, not a malignancy, but will be 1% per year transformed to malignancy, need close follow-up. No, not known etiology, no known etiology, no end organ damage, no hypercalcemia, no kidney failure or renal failure, no anemia, no bone lesion, no amyloidosis, no more than 10% plasmacytosis, no hyperviscosity syndrome, no macroglobulinemia. With all this, no rule of no for megas, you should when you see any patient with megas monoclonal gammopathy of unspecific or undetermined significant, you should put this in your list or your mind, not a malignancy. You should tell your patients it's not a malignancy, but this a pre-malignant need follow-up. Not known etiology, we don't know the etiology. No end organ damage. CRAB, you should check all by your investigation or biochemistry. No hypercalcemia, no kidney failure, no anemia, no bone lesion. I think this is under this end organ damage. No amyloidosis, no more than 10% plasmacytosis in the bone marrow, no hyperviscosity syndrome, no macroglobulinemia. And we'll discuss all this in details. What is the diagnostic testing available? This is the main aim to this topic. I need you to understand the next few slides. This is my message for you. I need you to learn that because I learned it by difficulty, as it is not easy to learn and to remember. But if you listen this time, I am sure you will not forget ever. And better than you read many books and you will not understand this, I will give you how you can investigate this patient with monoclonal gammopathy or multiple myeloma, whatever, the same investigation. How many myeloma cells are there in the bone marrow? Just bone marrow biopsy. This is mandatory. You should do if you suspect any patient with myeloma or megas, whatever. Serum free light chains is mandatory. Serum protein electrophoresis also. Urine protein electrophoresis. And hemoprotein and the quantitative IgG, IgM. I think this is under SBE and UBE. And the other, what is damage is being caused to organs or symptoms, calcium, high or no, from lytic lesion, from osteoclast activation, hemoglobin anemia or no, from plasma cell infiltration of bone marrow, hematocrit, also for anemia, estimated GFR, creatinine for kidney function, urea, and white blood cells for infection, and imaging for lytic lesion for the bone. Okay, this just for damage, and this for to check the activity of your disease, if your disease is active or no, by serum protein electrophoresis, urine protein electrophoresis, serum free light chain, bone marrow biopsy is the main test, and this biochemistry and the lights and CBC and renal panels and imaging for lytic bone lesions, all this to check organ damage, and this for activity of your disease. Serum protein electrophoresis, the most commonly used lab test for detection of monoclonal protein. monoclonal جاي من ايه؟ mono يعني واحد وكلونال يعني خلية واحدة، بروتين. تمام. The most commonly used laboratory test for detection of monoclonal protein, serum protein electrophoresis. Electro يعني electrical, and phoresis means separation. Phoresis separation. Don't mix this by plasmapheresis, whatever. Apheresis means taking away the plasma antibodies, is the plasmapheresis. But we have here electrophoresis. Phoresis separation. electrical by جهاز بيبقى الكهرباء، جهاز كهربي كده بيعمل separation للبلازما بروتينز. تمام. separation. لكن this take away is the plasmapheresis different. Okay. This is electrophoresis and immunofixation, separation and detection of serum protein to detect multiple myeloma. Just we are putting in the electrical machine and we'll connect the power. And when you're putting your sample plasma here, the protein will be separated, will be moved from negative charge to positive charge. And we'll see this in details, and we'll give you this diagram will be rising here. Will be just drawing here this diagram already on your computer or your desk. And with electrophoresis, just separation of the component of the plasma protein, negative charge here, or negative electrode, and this positive electrode will connect our power supply electricity. Movement direction will move from negative electrode to positive electrode according to mass and the charge, and this automatic will draw. When this start to work, your button on already, and this start will draw this diagram for your immunoglobulins and the proteins, and you'll see here according to mass and the charge, the protein will be fixed there. The albumin will give you the largest spike. This is the normal diagram for serum protein electrophoresis. Okay, with the normal diagram, the albumin will be fixed because you have already high proteins, and the albumin will be fixed here. With this high spike, and this alpha 1, alpha 2, and beta, and this gamma with our immunoglobulins already. Immunoglobulin gamma here will be diffused. This one will take long time and will be diffused with the normal pattern of serum protein electrophoresis. Okay, I hope that's clear now. And with also normal pattern albumin here, and with alpha 1, alpha 2, and the beta, and this gamma, diffuse gamma here. And this according to this is the immunofixation picture, and this abnormal here. This is the normal one, and this abnormal one. This means M spike, monoclonal protein spike here. You will find on the gamma, in diffuse gamma immunoglobulin, monoclonal proteins. Just to know the normal pattern and this abnormal one. This is M spike monoclonal protein positive here. And this normal pattern, albumin here, alpha, beta, and the gamma here, diffuse gamma, and this immunofixation, found this fixation already positive for G and lambda. G and lambda, these two light chains and this heavy chains is positive for immunofixation just done for G and lambda. Plasmacell description or monoclonal gammopathy, as we mentioned before. Monoclonal, I told you only one cells, one crazy cells, one antibodies. This gamma يعني gamma globulins باسي اللي هي باثولوجي. يبقى monoclonal gammopathy هنا monoclonal only one cell, one crazy cell, secrete more antibodies. Okay, single heavy or light chains, whatever. These antibodies either heavy or light chains. Gamma globulins, pathology, BASI يعني pathology. This already, but already we have here, when you do serum protein electrophoresis, already we have this M spike now, this M spike, M component, or what his name is monoclonal spike for this gamma globulins. This pathology will be here. But the problem here in serum protein electrophoresis, just to give you the same spike, this is positive for monoclonal gammopathy, M spike, but we don't know what is the subtypes for this M spikes. This is heavy chains or light chains or both or whatever, we don't know. You should, but this is a problem here. We don't know which subtypes of gamma globulin is high, IgG or IgM or IgA or lambda or kappa. We don't know this M spike now. What is the type? This is the serum protein electrophoresis. Just to give you the same picture here with serum protein electrophoresis or urine protein electrophoresis, you'll give you this spike only, but we don't know what is the subtypes of heavy chains or light chains, IgG or IgM or IgD or lambda or kappa, whatever. This is the end result of serum protein or urine protein electrophoresis by this M spike, monoclonal spike. We need now the second test, and we'll set it clear now, I hope. And this again, this is a normal serum protein electrophoresis. This is albumin, this is alpha 1, alpha 2, beta, and this is diffuse gamma. Gamma globulin here. Gamma globulin will give you a spike for monoclonal protein. This abnormal serum protein electrophoresis. We need next step to know what is the subtypes here. And this again, this is a normal one, and this M spike here in place of gammopathy of gamma globulins. The monoclonal protein spikes, this one and this normal already, this albumin, but the albumin here and this M spike monoclonal protein. But there is one problem, as we mentioned, we don't know subtypes of gamma globulin is high. I don't know, this IgG, IgM, IgA, IgD, or lambda or kappa. So how to solve this problem? Forget now serum protein electrophoresis, urine protein electrophoresis. We'll think now immunoelectrophoresis or immunofixation. So when you request serum protein electrophoresis, you should ask for serum immunoelectrophoresis or immune fixation. Immune fixation is the most important. The immune fixation just will add antibodies to antigen, anti-A, anti-G, anti-M, anti-D, whatever, anti-kappa, anti-lambda, will add antibodies to all subtypes of heavy and light chains. Anti for all subtypes I mentioned before, heavy chain, gamete, قوي, heavy, gamete, GE, MDE, and this light, just light, lambda, and the kappa will add antibodies to which one of that, which means by immunofixation, and will fix what is the problem. I hope that's clear. Okay, now after immunophoresis, don't forget immunofixation. No benefit from immunophoresis. Just immunophoresis will give you a positive M spike or monoclonal. But I don't know what is the subtypes. So what is subtypes? We'll see what is subtypes now. By this. So now I need you to organize now your mind. So which test can detect monoclonal gammopathy? Monoclonal gammopathy. Which test? Number 1, SPEEP, CPEEP, 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 serum protein electrophoresis. Serum protein electrophoresis. Did the quantify, ده بيعد بس مش qualify. Quantify not qualifies. Quantify M components ده اللي بيطلع لك الM spike فقط لا غير. Doesn't tell you which M protein is increased. كابا, لامدا, IgG, IgM, IgA. يبقى CPEEP or serum protein electrophoresis quantitative but not qualitative. Qualitative. You can repeat that if you like. As I mentioned, the serum protein electrophoresis, the quantitative diagnosis and follow-up تستخدم في الدياجنوز بتاع المونوكلونال gammopathy or multiple myeloma for diagnosis and follow-up also. Not sensitive enough in low burden disease. لو عندك يعني disease not aggressive, detection limit for M proteins 3 to 5 gram per liter gamma region, up to 7 gamma per liter alpha and beta region, and positive in multiple myeloma only 87% or around 88%. يبقى now serum protein electrophoresis just positive around 88%. Amyloidosis just 73 or 74%. Light chain deposition disease around 55%. Doesn't differentiate between the M types, M proteins types. Just to give you M spike only, and multiple myeloma just diagnose only around 88% sensitivity for him, and the amyloidosis around 74%. Light chain deposition disease around 55%, and will mention for you when you'll add another test, this percent will be around 100. This immunofixation, most sensitive test. Immunofixation, most sensitive test, but expensive and qualitative. Identify. دلوقتي هيعرف لك الام بروتينز تايب. الام سبايك دي، السبايك اللي طلعت لنا دي، هقول لك التايب بتاعها جي ولا اي ولا ام، الهيفي تشينز ولا اللايت تشين، لامدا ولا كابا ولا. تمام. improve detection, multiple myeloma around 88%, AL amyloidosis around 67% also, and we'll see. Urine protein electrophoresis, UPEEP quantify also, ده بيعد بس light chains in the urine كابا و lambda ده بنسموهم Pence Jones protein. doesn't tell you which protein is increased either كابا or lambda. ده برضه ما بيديكش الحته دي، بيديك السبايك وخلاص. UPB is a quantitative but not qualitative. You need also fixation. Theorem immunofixation or electrophoresis. Immunofixation electrophoresis specifies the hemoproteins. Hemoproteins اللي سبايك دي اما either كابا or lambda IgG or كابا or lambda cannot quantify the M component. تمام. Serum immunofixation or electrophoresis. ده الاميونوفيكسيشن يا سيدي لما يجي لك بالمنظر ده بيجي لك الريزلت ده بوزيتيف IgG immunoglobulin G and lambda، يبقى بتسموهم بوزيتيف IgG لامدا مونوكلونال بروتين. ده الدياجنوز بتاعك لما بيجي لك بالظبط في الريبورت بتاعك، المفروض يقول لك بوزيتيف IgG لامدا مونوكلونال بروتين. ده الدياجنوز، لان حصل فيكسيشن هنا في الجي، حصل فيكسيشن في اللامدا، فبيسموهم بوزيتيف immunoglobulin G lambda monoclonal protein. Urine immunofixation electrophoresis specify whether Pence Jones protein is light or kappa, cannot quantify. Also الام spike ده مش مسؤول عن الام spike. الفيكسيشن ماليش دعوه بالام سبايكس. سيرم بروتين الكتروفوريسيس ده بتاع الام سبايكس. الفيكسيشن ده مسؤول بيحدد لك التايبس في اليورين وفي السيرم، وحدد لك التايب IgG heavy chains or light chains. Both tests are qualitative اللي هم الفيكسيشن في السيرم واليورين but not quantitative. Okay. We'll give one case to Pastor ratio. 80 years male with back pain. Most patient take care elderly patient back pain, hypercalcemia. Just put your triad in your mind. When you check your patient in emerge or consult or clinic, elderly patient complain of light back pain. You know, most all our patients complain of whatever generalized pain all over the body, but especially this patient elderly complain of back pain with calcium high, with AKI, and a little bit anemia, normocytic normochromic anemia, and just think this patient may be megas monoclonal gammopathy, and this patient maybe needs serum protein electrophoresis and immunofixation at the same time. And this paper already done for the patient just will give you this spike for immunoglobulins or monoclonal gammopathy. Here the spike is abnormal shape, and you should go to immunofixation, and here already the immunofixation came positive for G and the kappa. This diagnose, our diagnose IgG kappa monoclonal protein. IgG kappa monoclonal protein. I think now that's clear. Serum free light chain assay. What is the benefit to add when you ask your hand كده right SPIP UPIP, just put also FLC please. Just don't forget FLC to put in your request to complete, to be 100%. Don't miss any diagnosis for this monoclonal gammopathy. Just please add serum-free light chain assay of monoclonal protein. This is already discovered around the early 2000 with using antibodies against epitopes. I will show you now in the picture what it means by epitopes that are normally hidden in intact immunoglobulin that assay detect both kappa and lambda free light chains. It is a quantitative and automated abnormal ratio between kappa and the lambda free light chain is detected. The normal ratio, as we mentioned before, 0.2 to 1.6, 0.2 to 1.6. I need you to understand this, to understand what is this free light chains, how we can detect this. This is a normal intact immunoglobulin. We can't detect this now because already hidden epitopes for the free light chains, the surface for the free light chains already hidden here. We can detect this. If you have intact immunoglobulin, with the light chains, this is a heavy chain, this is a heavy chain, heavy chain, light chain, and this the epitopes or bisexual, this epitopes here that just join this together, heavy and light chain. Now, when we have overproduction for this free light chain, will be this epitopes will be exposed. You can detect this in your test already, free light chains, either by electrophoresis or fixation. Then you will see here this epitopes already exposed and easy to be expressed and to be detected in your test. Or okay, I think that clear now. The intact immunoglobulins and hidden epitopes of free light chains, we can detect that, but already with the overproduction, these epitopes will be exposed surface, and we easily detect in your urine, especially urine and the serum free light chains. Now, normal value. This kappa free light chains 3.3 to 19.4 milligram per liter, and lambda 5.7 to 26.3 milligram per liter. Kappa to lambda serum free light chain ratio, serum better than urine, please. Don't, because if you have serum, that's enough. Don't much expand the economic burden your patient. This is a kappa and lambda serum free light chain ratio range between 0.2 to 1.6, median one. Just don't forget 0.2, 1.6, okay? And this now exposed to epitope, as I told you, this is easy to be detected. Either lambda or kappa or lambda exposed already, easy to be detected in your test. Free light chain does not differentiate monoclonal from polyclonal. Normal ratio, as we mentioned, 0.2 to 1.6. Normal ratio in kidney failure, 0.3 up to 3. 0.3 to absolutely 0.2, 1.6. 0.2 increase to 0.3, and 1.6 increase to double to 3. This is in patient with low GFR or kidney failure. In combination with serum protein electrophoresis. Now, I request serum protein electrophoresis, serum free light chains. This combination will improve detection of your monoclonal gammopathy or disease. Light chain disease will increase from 55% to around 78% or 77%, whatever. Light chains will be increased from 55. Amyloidose will increase from 69 to 96% in detection or diagnosis. Multiple myeloma will be 100%. 100% from before, 88% if you remember last slide, if you can go back. But now adding combination of this serum free light chains with the serum protein electrophoresis improve detection of your malignancy or disease, either light chains or amyloidosis or multiple myeloma by 100%, especially with multiple myeloma. Either quantitative, automated test, useful and just important in monitoring treatment response if your patient under chemotherapy. I'll مثال example, some patient, the patient already result already came with normal value here already for kappa and the lambda, and the ratio 0.2 to 1.6, and the patient just presented by fatigue. We requested for him, we found the kappa 15 and the lambda 24, all this was a normal, and kappa lambda 0.7 was a normal. No monoclonal protein, I am comfortable observing in the serum, on the serum protein electrophoresis. Okay, serum protein electrophoresis. Here, kappa is 15, patient also same complaint of fatigue, and the lambda 24, and this, according to this free light chain result, no evidence of monoclonal light chains. This is the free light serum free light chains. No, this is the same patient. Serum free light chain, no evidence of monoclonal light chains. Second patient came by back pain, fatigue. Kappa 500, lambda 25, kappa lambda 20, monoclonal protein detected on serum protein electrophoresis. We have here positive kappa lambda ratio, and this is high already. And that little bit on borderline with monoclonal protein detected in serum protein electrophoresis. Our diagnosis indicate monoclonal kappa free light chains because the kappa is high here. This means you have monoclonal kappa free light chains. This is the benefit of this serum free light chains will determine kappa or lambda. Free light chains is return back to our component of our heavy chains and the light chains. The light chains just only kappa light, only two, kappa and lambda. Heavy chains, IgG, heavy, gamete or Majdi as you like, gamete, G, E, A, M, D, whatever, yeah, just to enumerate. We are now in serum free light chains, either kappa or lambda. Kappa here is high, this means monoclonal kappa free light chains. And here example 3, if patient came by fatigue, bone pain, and the kappa is 1.1, the lambda is too high, 220 normal here for lambda, for 5.7 to 26 is the normal, and the ratio 0.005. This faint monoclonal protein observed on a serum protein electrophoresis, and the patient monoclonal free light chains. Monoclonal free light chains. I think this is a good example how to read and how to request this test and this test, and now that's clear. Don't forget serum protein electrophoresis, serum immunoelectrophoresis or immunofixation. Both will detect these types of IgG, whatever. And this theorem free light chains with fixation will give you kappa or lambda with heavy chains by laser test. And finally will end by my diagnosis. My diagnosis, IgG, for example, IgG, immunoglobulin G, lambda, monoclonal protein. This is your diagnosis after all this test. Sensitivity of serum protein electrophoresis at diagnosis. As we mentioned, serum protein will give you 88% of multiple myeloma, and the amyloidosis around 66%. We discussed this before. In amyloidosis, the serum free light chain عشان increase لما بتستخدم لما تيجي تشخص عين amyloidosis وتستخدم الفري لايت تزود الفري لايت chain في اللاب بتاعك، ده بيزود الديتكشن بتاع الريت بتاعك من 69 to 99%. It's too much. And the multiple myeloma increased from 88 to 100% also. يبقى الفري لايت chains is important to detect small antibodies or amount in your urine or serum. Better to use this serum free light with the serum or urine protein electrophoresis. Just do serum, better don't forget urine now. Why use free light, serum free light? At initial diagnosis, serum protein electrophoresis plus free light, 100% of multiple myeloma, as we mentioned for you, and around 96% of myeloma will be diagnosed when we add serum protein electrophoresis with the free light chain. To monitor response of the treatment, we'll use this as a monitoring for your patient under chemotherapy to adjust the therapy if treatment not working. ممكن تشوف الليفل بتاعك لو disappeared already، ممكن تزود التريتمنت او تقلل. When in remission, to monitor for relapse. The most important one in relapse, if light chains, and I will show you now. Because the light chains will appear rapidly and disappear rapidly, but heavy chains will take time to appear again or relapse again, not like light chains. Light is light in everything. And when in a remission, to monitor, we are using this free light chains for relapse and regrowth of myeloma cell to be compliant to international guidelines, at least to be with العالم اللي ماشي حوالينا دي. ما تبقاش انت ماشي في سكه وما فيش حاجه فيها توفير يا جماعه. يعني الصحه ما فيهاش توفير في لما تطلب التحاليل دي انت ما بتوفرش العيان ده، انت بتحمل عيان انه ممكن يصرف مثلا 1000 جنيه مثلا او $1000 دلوقتي، ممكن يصرفهم 20,000 بعد كده. فانت كل ما تشخص الحياه بدري بتفرق مع المريض جدا يعني. Short half life of the serum free light chains allow rapid response of assessment. rapid response of assessment. انت عندك هنا الهاف لايف بتاع الكابا واللامدا هو اول اثنين على الشمال، على شمالك دول 2 to 6 hours. بعد كده الاميونوجلوبولينز كلها بتاخد دايز لويكس. بعد كده اي جي جي سبيشال اي دي بياخد 21 days 3 weeks. يبقى انت عندك الهاف لايف طبعا، هتفرق معاك. هوريك ليه صوره الهاف لايف دي هتفرق معانا. هنا لما بتعمل مثلا فول اب للعيان او بتدي تريتمنت للعيان اللي بيختفي بسرعه، مين اللي بيحصل له كاتابوليزم ويوصل ده اللايت تشينز كابا فري لايت تشينز اهو مونوكلونال اي جي جي. ده الدايجنوز بتاع المريض بتاعك اللي هو اي جي جي كابا مونوكلونال جاموباسي. اي جي جي كابا مونوكلونال جاموباسي. انا لما اجي بتابع بالسيرم بروتين اكتوفوريزيس والسيرم فري لايت تشينز. فانت لما بتيجي تتابع تشوف الفري لايت تشينز اوبا دراماتيك ريسبونس. ده الدايز اهو من التريتمنت، وده الليفل بتاع الايه الكابا والاي جي جي بتاعنا. ادي المونوكلونال اي جي جي اللي هو لونه بني، ده لونه بني بياخد وقت على ما ينزل او على ما يجيب ريسبوند معاك. لكن الفري لايت تشينز اللي هي الكابا ديت بيحصل لها رابيد دراماتيك ريسبونس زي ما انت شايف. دراماتيك ريسبونس ده الميزه ان ايه بتاعت الهاف لايف اللي قلت لك عليها بتتكسر بسرعه. هنا في الفولو اب انت هنا حصل دراماتيك ريسبونس اولسو. هنا الاي جي جي اللي هو الاخضر ده اللي هو مين؟ الهيفي تشينز الاي جي اي. الدايجنوز بتاعنا هنا اي جي اي لامدا، وده اللامدا اللي هو الايه البني، اللامدا البني، وده البورتيزيماب. عيان بتاعنا بدا مالتيبل مايلوما وبدا على بورتيزيماب، وبتشوف الايفكت بتاع التريتمنت بيحصل له رابيد. لما بتتابع الاثنين دول بتلاقي اللي هو الايه اللامدا فري لايت تشينز، شوف دراماتيك زيرو، دراماتيك ريسبونس، لكن الثاني ده بياخد وقت على ما ينزل. طب انت لما تيجي تعمل فول اب، لو انت حبيت توفر العيان وعملت ناصح او وفرت للعيان، قلت نعمل سيرم بروتين كفايه. فانت يا معلم لو عملت الكلام ده سيرم بروتين تفريز مع الفيكسيشن هتشوف الاي جي جي وصل فين. ممكن الاي جي جي لسه في سبريس، بس انت لما تعمل ولسه شغال سبريس ده، خد بالك اللي هو ايه الاخضر اللي انت شايفه الجرين 1 هذا الاي جي اي. if you do only if you will do one follow up serum protein electrophoresis and fixation and you forget to put free light serum free lights, maybe this will be missed here, will be this area, this serum free light chains here, lambda chains will be appear as a relapse here. You should discover this early. Don't يعني ما تحاولش توفر العيان، انت ممكن توفر تاذيه فمالهاش لازمه. انت لو هتعمل فولو اب تتعامل صح زي ما انت شايف. حط دي في دماغك دايما، انا لو عملت فولو اب واحد بس من الاثنين سيرم بروتين وتفريزز وفيكسيشن، وعملت فولو اب وسبت انا السيرين فري لايت تشين، ممكن يحصل ريلابس لللايت تشينز هنا وانا ما ناخدش بالي منه، والعيان يكون وقف العلاج او قللت علاج او ايه يحصل ديتوريشن للمريض. Why did my free light value change so suddenly? And ده normal biological variation between 20-30 day to day variation. Where you test just check in maybe الدراماتيك او التشينج ده ممكن يكون different value from lab to lab or machine. Better to send to different lab and check on the baseline for your machine to keep your baseline for your patient. ممكن تبعت 2 سامبل تانيين لمعمل تاني لو انت اتاكدت، لو لقيت في دراماتيك ريسبونس كده ومش ماشي مع العيان ولا الكلينيكال بتاع العيان والعيان بتاعك ستيبل ومديك ابنورمال ريزلت، بالله عليك ممكن تعيدها في معمل تاني وتشيك على حسب المعمل اللي انت ماشي معاه وعلى حسب الستاندر اللي انت ماشي بيه قبل كده والبيز لاين بتاع العيان بتاعك. ده الغرض من الصفحه دي كلها، ان انت ايه تعمل كومبير للريزلت مع البريفيوس وان، ولو لقيت في اي حاجه ابنورمال مش ماشيه مع العيان بتاعك او كده في حاجه كده غلط في الموضوع، اللي هي تعيد في معمل تاني، يا اما تعيد على الستاندر او تعيد او تقارن على البيز لاين او تعيد في معملين لو انت تقدر كمان، لو العيان يقدر ممكن يعيد الريزلت في معملين عشان تقارن الريزلت مع بعض وتشوف. ده الغرض من السلايد دي. ايه هي الادفانتج بتاعت السيرم فري لايت تشينز عن اليورين؟ هنا بس هي اناليتيكال سنسيتيفيتي، قال لك السيرم فري لايت طبعا بيج سيجنيفيكانت ديفيكالت بيج سيجنيفيكانت اسمها ايه دي؟ sensitive more than اليورين، يعني السيرم احسن من اليورين. وانت عارف السيرم فري لايت تشينز بيحصل لها كاتابوليزم وري ابزوربشن باي البروكسيمال تيبيولز والديستال تيبيولز اكسكريشن وكده، فدايما ما بتبقاش بس السيرم افضل من اليورين في الحته دي، لان هو مينلي يورينري اكسكريشن. عند اليورين كومبلاينس ممكن العين بتاعك ما يجمعش، لان انت تحتاج تجمع 24 ساعه يورين، ممكن العين يجيب لك ما يجمعش كويس، ممكن الكومبلاينس بتاع التجميع بتاعه مش كويس، فاحسن حاجه تستخدم السيرم فري لايت. السيرم فري لايت better than اليورين free light chains for this issue and this analytical sensitivity. We found the free lights better than اليورين in the result and the renal catabolism بيحصل لهم reabsorption and the excretion and the metabolism. ده كل ده بيأثر على الريزلت بتاعتك. انت ممكن تعمل وتلاقيها low او not determined, but if you do serum you will found significant difference. يبقى now free light chains more than 10 times more sensitive than يبقى هنا more than 10-fold more sensitive than the urine free light chains immunofluorescence, and this renal catabolism not always found in urine because this reabsorption and this excretion and the poor urine collection with compliance of the patient not good for 24 hours maybe will give you a significant or inaccurate result for your urine free light chains. Free lights in serum is recommended in international and Canadian guidelines at diagnosis for monitoring and in prognosis. Enhances sensitivity compared to serum protein electrophoresis and urine protein electrophoresis. Rapid evaluation response and depth of response. equivalent or superior to urine analysis. Detect light chain escapes, especially with the serum. Serum free light chains level correlate with the survival and prognosis. We think that serum free light chain small, significantly important in your diagnosis, screening and monitoring. Just in screening and monitoring in your patient, don't forget to add serum free light chains with immunofluorescence or immunofixation for serum protein electrophoresis. This will increase your sensitivity to 100%, especially with multiple myeloma. And this the pros and the cons you can read if you have time. Take a picture and read. This for serum protein electrophoresis and serum immunofluorescence fixation, and the serum free light chains and the urine protein electrophoresis and fixation. Both you should order all these labs together. Serum protein electrophoresis advantage is low cost, fully automated, quantitative, and normal, as we mentioned, for hemoproteins limits 0.3 to 0.5 gram per deciliter. And as we mentioned before, just this serum protein just to give you limb spikes, and they will not give you subtypes for each one. And you should do this immunofixation to give you subtypes for each heavy chains and light chains by the immunofixation. And this urine protein electrophoresis already discovered, first described in 1946 by Dr. William. Urine examination, no evidence of sugar in urine, ring protein. After that, progressed by third opinion from Dr. Henry Pence Jones. The lowest sensitivity, serum protein electrophoresis positive around 94%. Urine protein electrophoresis will be positive by only 40% from 94% by serum. Never use alone. Don't use alone. You can use with the serum protein electrophoresis. Replaced now already with the serum free light chains for screening. If reduced kidney function, take this message for you. If you have reduced the kidney function plus hemoproteins, spike, protein spike, as we mentioned, plus low albumin on urine protein electrophoresis, consider cast nephropathy. If reduced the kidney function plus hemoprotein spike and the high albumin on urine protein electrophoresis, just consider light chain deposition disease or amyloidosis. Low albumin with others and low GFR, this cast nephropathy, high albumin with reduced kidney function, this amyloidosis and light chain deposition disease. Positive urine protein electrophoresis increase the risk of renal injury in myeloma. And if you can read later, this what is Pence-Jones protein. This light chain is needed to combine with the heavy chains to create whole immunoglobulins. Is intact immunoglobulin, as we mentioned before. Sometimes the myeloma cells produce a light chains in large quantities without being attached to the heavy chains as exposed to epitopes. We can diagnose this in urine as a Pence-Jones protein, as we mentioned before. Serum free light chains, antibodies against epitopes that are already exposed, normally hidden in intact immunoglobulins, as we mentioned before. If you would like to go back to our pictures or our slide before, detect post cap and lambda free light chains, quantitative and automated test. The assay is not specific for monoclonal light chains, but instead infers in monoclonality or in ratio is abnormal. Normal ratio 0.2 to 1.6. If you have a patient with CKD, just increase 0.2 to 0.3 and 1.6 increase to 3. We have now in patient with AKI or CKD 0.3 to 3. This is normal ratio for our patient. Okay, just summarize. Our lab don't investigate serum protein electrophoresis. You will order urine protein electrophoresis as you like. Serum protein in electrophoresis with immunofixation with serum free light chains and fixation. Take a home message or home point. Monoclonal protein testing is an important diagnostic tool for evaluation in patient with AKI and proteinuria, especially in oncology department. Serum free light chains assay significantly increase detection rate of monoclonal protein when added to serum immunofixation. Don't forget that. Urine protein electrophoresis can help to differentiate between tubular and glomerular injury in patients with multiple myeloma. Don't forget also that. Okay, as I mentioned before. The most accurate test to diagnose multiple myeloma is bone marrow biopsy. The most accurate test to diagnose any patient with multiple myeloma is bone marrow biopsy. Multiple myeloma is one type from monoclonal gammopathy. This is at the first slide. I give you the monoclonal gammopathy around 70 or 80%, and the other will after that will progress. This is a pre-malignant condition, will be deteriorate to multiple myeloma or amyloidosis later. Only multiple myeloma, just one type from monoclonal gammopathy. And this picture of bone marrow biopsy taken from symphysis pubis, oral hip bones. When do you decide to do kidney biopsy for oncology patient, CKD with monoclonal proteins? CKD with monoclonal protein, when you decide to do kidney biopsy, when patient with protein, with patient CKD with monoclonal protein, or patient with proteinuria more than 1.5 gram, proteinuria more than 3.5 gram, hematuria, proteinuria, and explain the drop in GFR, decision based on hematological parameters. I think the most choice here is this taking for A and C, A, CKD, and monoclonal protein. We can decide to do that. And already see the most common choice by our colleagues is proteinuria more than 3.5 gram, hematuria, proteinuria, maybe other indication, proteinuria, maybe other indication, more than 1.5 grams. I think most of this, you can decide according to the kidney function deterioration and the follow-up of your patient. If deteriorate, you should do kidney biopsy and diagnose your patient. CKD with monoclonal, I think you should do, and proteinuria more than 1.5 gram. If deteriorate kidney function, you should do proteinuria more than 3.5 gram. Also, patient came by hematuria, proteinuria, and explained AKI or progressive AKI, you should do, and explain deteriorated kidney function. I will do decision based on hematological parameter. No, not that. We can do bone marrow biopsy and diagnose patient in the last step for hematological parameter. What do you biopsy this patient? And I just will give you a case, 82 years male patient, referred with progressive CKD, and it's already by Dr. Sarah Moran. And the patient referred by progressive CKD, and past medical history is megas already, monoclonal gammopathy if undetermined significant, or unspecific significant, and hypertension, obesity, creatinine 206, albumin 33, ICR, albumin creat ratio 10 milligram per millimole, and urine analysis trace a hematuria, and free kappa 77, and kappa ratio around 2.1. 2.1 with this ratio already been kappa or lambda, and with this creatinine is normal. Up to 3 is okay for me. What you will do kidney biopsy for this patient or no? I think most some told no and some told yes. And the patient with ACR now around 10 is microalbuminuria. You will do or no with this serum creatinine 200. This is 82 years patient, CKD, hypertensive, also obese, and with megas already. You will do kidney, and he's stable for that laser. You will do or no? And most our colleagues said choose no, will not do biopsy for this patient. Whatever you will do or no, we'll see now. Or if you said yes, I will do. What do you expect to see for this patient? 82 years, hypertensive, obese, and diagnosed as a megas before. You will see atherosclerosis or focal segmental secondary to obesity, or MAGRAS, monoclonal gammopathy of renal significant, or tubular interstitial nephritis. And I think this is patient 80, hypertensive, obese, maybe atherosclerosis, maybe focal segmental, we'll see. Indication for kidney biopsy, whatever, either hematuria, if no urological cause, and proteinuria more than 1 gram. This according to up to date on native kidney biopsy, core curriculum already in 2019. Just decide to indicate kidney biopsy. Patient with hematuria, proteinuria more than 1 gram, unexplained AKI, unexplained CKD also. Will this biopsy alter my management? Is the patient candidate for therapy, clone-directed or immunosuppression, absolute or relative contraindication to biopsy? If there is the diagnosis based on other issues or amyloidosis based? These are all, you should put all this in consideration and indication in your mind. If I face one patient with hematuria, proteinuria, and then explain the AKI with proteinuria around 1 gram, and explain the AKI and CKD, you should proceed for biopsy, whatever. And just put in your mind, before any biopsy, you should consent your patient and discuss with him the risk of this kidney biopsy, and you can explain for him, according to Jason already, to explain this is the complication, the most common complication in the post-kidney biopsy. Just by this analysis by Jason already shows us around 11% each 111 patient will be with hematoma, and around 1.6% with bleeding requiring blood transfusion, and around 4 to 3% with pain at biopsy, and 0.3% bleeding requiring intervention, and 3.5% with microscopic hematuria, and other complication is too rare, as I think surgical intervention or this already is too rare to be happen. And I will give you a kidney biopsy presentation, how to discuss the risk and how to remember all this. But don't forget hematoma and the pains is the most common, and followed by this microscopic hematuria, and it maybe bleeding need blood transfusion 1.6%, and the other bleeding need intervention 0.3%. It's too rare, and the risk of this you should, and the nephrectomy you should discuss all this risk, and we'll discuss this in kidney biopsy round. Don't worry for that. And the useful diagnostic test for initial evaluation if any patient or CKD, as we mentioned before, don't forget serum protein electrophoresis, urine protein electrophoresis, or serum and immunofixation with serum free light chains. And this CRAB, don't forget also CRAB and the CBC by hemoglobin and the kidney biopsy. All this diagnostic test for any patient and explain CKD or AKI. Case 1, our patient already biopsy done for him, atherosclerosis, global glomerulosclerosis. Atherosclerosis may be hypertension, elderly patient, global obese and hypertension, all this prostate, also this glomerulosclerosis. Case number 2, 68 years man, present with routine blood work, and he found us only hyperlipidemia and receive regular blood work for his monitoring his liver function. Don't forget, when you prescribe any statins, just don't forget to follow liver function, because it's nephrotoxic and maybe will elevate your liver enzyme by next 2 weeks or 1 month. He all has no compliance and feel well, and no complaint and feeling well. His examination is without abnormal findings. This is our patient, 68 man, just came for routine blood work, just found hyperlipidemia. We are giving a statin for that and follow up for his liver function with no specific complaint and doing well, and examination without any abnormal finding. Liver function that show normal ACT and ALT, total protein only 8.8, normal 8.3. Let's take care. 8.8 this is how to discover patient early before screening, just screening. You found a high total protein and the albumin little bit normal 3.7, was a normal little bit in a lower side, but is normal, but already with total protein is high. This patient had unexplained wide protein gap. Total protein is a little bit high, and the albumin 3.7, little bit in wide gaps. We have protein gaps. This is from total high protein with normal albumin. This we have gap here from where this non-albumin protein. Just albumin typically account for about half of total protein in the serum. We have gap here, maybe other paraproteins. You should think in other paraproteins, okay? And this normal serum protein electrophoresis, this albumin, alpha 1, alpha 2, beta, as we mentioned before, and this diffuse gamma. And this abnormal one with M spike here, monoclonal protein by serum protein electrophoresis. Till now, just to give you M spike. I have monoclonal gammopathy now, but what is type? You need fixation. Serum immunoelectrophoresis or serum immunofixation to detect what type of this M spike or monoclonal gammopathy, okay? To investigate the elevated total protein, serum protein electrophoresis as quantitative as we mentioned, we need this monoclonal immunofixation. Serum protein, just to give you prominent zone and restriction, this gamma regions at this monoclonal gammopathy. This part monoclonal gammopathy, we need immunofixation to detect what is this type, heavy chains and light chain, as we know here, because I will not repeat this again, I will just to remind you, this IgG kappa monoprotein. IgG kappa, this fixation happen here for our protein in G and the kappa. In IgG kappa monoclonal protein. I think is that easy now. Case 2, quantitative, just in, at the end, we found this IgG kappa monoclonal protein. IgG kappa monoclonal proteins around like that. Is positive. Further blood workup is performed, normal blood count, no anemia, and also metabolic panels, no hypercalcemia. And here, normal calcium, normal kidney function, and normal other blood count. The patient is referred to a hematologist for input, bone marrow biopsy. طبعا, you refer this patient to complete your workup. Just for bone marrow biopsy, just only 4% monoclonal plasma cell clones. Radiological skeletal, already radiology done was normal, no lytic lesion. The patient is given diagnosis monoclonal gammopathy of uncertain or undetermined or unspecific significant. Monoclonal gammopathy megas already. This is our diagnosis for our patient. Monoclonal gammopathy if undetermined or uncertain significant, then the monoclonal proteins less than 3 grams per day, monoclonal proteins less than 3 grams per day, less than 3 grams per day, not nephrotic range, bone marrow plasma cell less than 10%, absent signs and symptoms of like CRAPS of end organ damage. No end organ damage, bone marrow biopsy plasma cell less than 10%, monoclonal protein less than 3 grams per deciliter. The prevalence around 3.2% for Caucasian, more than 50 years old, and the prevalence male more common, and the age around 70 years, male more common than females. High Africans, black people more than white people. Average age at diagnosis 70 years. This is the most important. 3.2% Caucasian, more than 50 years. Median age around 70 years. Common in male than female. Black more than African American. Black more than white. 2 to 3-fold increase the first degree relative patient. Average age at diagnosis 70 years. Cause unknown. High prevalence in obese. Chronic antigen stimulation by pesticide exposure. All this will stimulate this megas syndrome. Classification in all megas is pre-malignant will be linked by multiple myeloma, Orion amyloidosis, or ciliary light chain amyloidosis, ciliary plasmacytoma, Waldenström, macroglobulinemia, and heavy chain disease. Megas, we know already unknown etiology. This pre-malignant clonal plasma cells. M spike present, M spike will found M spike but protein less than 3 grams, less than clonal plasma cell in the bone marrow biopsy. 1% population at 50 to 60 years, male more than females, black more than white. No treatment required. Patient must follow this need frequent follow-up. Risk of progression of malignancy for multiple myeloma, amyloidosis, Waldenström, microglobulinemia, non-Hodgkin lymphoma. The overall risk of megas progression to clinical at 1% per year. Yani each 100 will be 1 per year will be develop this multiple myeloma or amyloidosis. You should frequent follow-up for this patient. There is no way to tell if an individual with megas will progress or not. You can't guess your patient will be. ما تقدرش تخمن عنده هيبقى malignance ولا لا. So if the monoclonal protein increase more than 2 or other immunoglobulin A or M has 2-fold increase, and the IgG, other abnormality with the follow-up, need close follow-up for this patient. The patient has been observed every 6 months. With our patient, this is the case we presented now, observed every 6 months without any evidence of disease progression. At 2 years follow-up, he will be being annual بعد سنتين بتابع 6 شهور لمده سنتين وبعد كده كل سنه for evaluation of his megas transformed or no. Don't forget megas, not a malignancy, not non-etiology, no end organ damage, no hypercalcemia, no kidney failure, no anemia, no bone lesion, no amyloidosis, no more than 10% plasmacytosis, plasma cell in bone marrow biopsy, no hyperviscosity syndrome, no macroglobulinemia. Don't forget this sign with the follow-up. Any patient came by bone pain, low back pain, especially back pains and reps. Don't forget the back pains and his reps, fatigue. This is a common complaint. Weight loss, recurrent infection because immunosuppressed already, especially pneumonia and recurrent UTI, anemia, This, recurrent infection also for amyloidosis, and the anemia already. This patient will be anemia unexplained, nausea already, and hypercalcemia, serum creatinine increased, hyperviscosity, and the neurological. This patient may be paresthesia, especially in AL amyloidosis. Carpal tunnel syndrome is common. A patient with carpal tunnel, especially in hemodialysis patient, asymptomatic or minimal symptoms, around 11%. KBOint almost always an incidental finding. This most cases incidental finding. Remember to check the protein gap on and liver function test. No treatment indicated. Most patient will not progress to malignancy. However, virtually all patient require lifelong follow-up. Prognosis makes risk factor, as I told you, 1% per year transform to malignancy, especially malignant multiple myeloma. You should suspect by follow-up if proteins, monoclonal proteins increase more than 1.5 or equal 1.5 gram per deciliter, abnormal lambda kappa ratio, decrease 1 or 2 non-involved IgG. If IgG is high, laser will be suppressed. Case number 3, just will finish now this megas. Megas now will deteriorate to other disease, as we'll see in case 3. 58 years woman present for her annual examination. She feels well. Her past medical history include hypertension, for which she is taking atenolol. Her examination is without any abnormalities. Okay, just hypertension, taking atenolol, just came for her examination or annual screening. She recently attended a health fair. هتشتغل في شركة أو في مؤسسة. At her employers, رئيس العمل بتاعها اللي طلب منها request and present result of blood work obtained at the event. طلب منها تعمل تحاليل وتجيبها معاها الريزلت. On review, her blood count is normal. Her comprehensive metabolic panel entirely normal, except total protein is 9. We have now, and the album is 3.9 is now the album normal, and the total protein is high. We have gap, protein gap. We have unexplained protein gap now. Here, just to any unexplained protein gap, high protein, just is a message now. If you found this protein is high, total protein high, and the albumin is normal, we have gap here. Air protein, serum protein electrophoresis reveal marked zone of restriction in gamma region. And this comparison of protein spike, as we mentioned before, with by serum protein electrophoresis. And already we did already, you already have him spike by some need fixation. Fixation show IgA positive and the kappa positive, which means IgA kappa monoclonal proteins. Is this our patient diagnosis? She hematology should send the patient to hematology for bone marrow biopsy and radiological skeletal survey, just X-ray to see any lytic lesion or no. Bone marrow biopsy already showed 23 more than 10 monoclonal plasma cell in the bone marrow biopsy. She diagnosed with smoldering myeloma. Smoldering myeloma by this picture. We have M spike, we have 23 more than 10% monoclonal plasma cell and radiological no lytic lesion. Smoldering criteria. This monoclonal IgG or Ig proteins more than 3 gram per deciliter to more than 10%, more than 10 gram, okay? With more than 10% clonal plasma cell in the bone marrow, absence clinical sign, no lytic lesions, other labs okay, just plasma bone marrow and this monoclonal IgA kappa monoclonal gammopathy. Account for about 8% of all cases of multiple myeloma, median age around more 64, more common in men than women, male actor than female, often incidental diagnosis also. No treatment required. The clinical trial are currently evaluating early intervention. Just to follow this patient carefully, and patients are typically assessed every 3 to 4 months for sign or symptoms of progression. Most commonly, most common patient progress to multiple myeloma or amyloidosis at near future. The risk for progression is significantly different between megas and smoldering. Smoldering is high progression. And this criteria for high risk with patient monoclonal protein more than 4 is high risk. And the patient with A, IgG. Ig is more high risk, and bone marrow biopsy more than 50% is high risk percent for progression to multiple myeloma. Smoldering myeloma management. Patients are typically assessed every 3 to 4 months for some symptom progression. In this case, patient 2 has been, our patient followed by nearly 30 months now without any evidence of progression. She is considering participating in early intervention clinical trial at patient. And don't forget to, when you follow this patient, just don't forget bone pain, back and ribs, fatigue, weight loss, recurrent infection, anemia, nausea, hypercalcemia, AKI, hyperviscosity, neurological carpal tunnel. Don't forget the symptoms. Smoldering myeloma, key point, no treatment required. Consider referral for clinical trial participation. Risk of progression, as I mentioned for you, high risk, much higher risk for smoldering, as we see in the previous 2 slides. And trials in smoldering myeloma higher than el megas, and the risk of progression is highest in first 5 years. IgA high monoclonal protein and high bone marrow plasma cell increase the risk of progression, as we see in these 2. Smoldering myeloma and el megas in first 5 years is higher with the smoldering myeloma than el megas, and here patients with monoclonal proteins and IgA and high monoclonal proteins is higher risk for progression to multiple myeloma than el megas. Case number 4, 62 years man presented by his daughter to the clinic. She says over the past 2 days, he became increasingly confused and disoriented. Her father, 62 years man, and started to be confused in the past few days or 2 days, confused, disoriented. He was seen about 3 months ago for back pain that seemed to improve short term non-steroidal. جاي بباك بين وراح ادى المعلمين non-steroidal. Take care from any back pain to give non-steroidal for elderly patient. Temperature, baby, especially with AKI, check his kidney function first and think in this monoclonal gammopathy. Temperature a little bit febrile, heart rate 115, respiratory rate 24 and 160, 90, blood pressure, pale, disoriented, 2 place time person, and mucous membrane very dry, tachycardia, regular, sinus rest, abdomen is tender to palpation, basic lab, white blood cells, leukocytosis, hemoglobin is low, with platelet 1, 2, 2 is low. I think now is by cytopenia with leukocytosis. Basic lab test, total protein is 10, and albumin 3.2. We have huge protein gaps now. If total protein is high, with little low albumin, protein BUN is high, creatinine is 2 bonfire is high, and hypercalcemia is 2, all criteria for multiple myeloma. This patient transferred to emergency, admitted hospital, hypercalcemia treated with IV fluid because the patient too dry. He is seen by consultant hematology, and already we requested for all his workup, as I mentioned before, serum protein electrophoresis, serum fixation, serum free light chain, and finally he diagnosed as IgG kappa monoclonal proteins. Multiple myeloma, our diagnosis, bone marrow biopsy done already 64% monoclonal plasma cells, 60 more than 10%. Radiological skeletal surface show numerous lytic lesion with compression fracture in his lumbar spine, and the fracture already seen in lumbar spine. The patient diagnosed multiple myeloma. And just to remind you, this carpal tunnel syndrome here, and this hip pain, neck of the femur, and this is the back pain, the most common, this and this back pain, and this carpal tunnel pain or hip pains. Just don't forget this. Thighs, most common pain of multiple myeloma, and this picture shows this as just spinal cord compression here in multiple myeloma patient. This is an emergent situation, especially a thoracic patient will develop paraplegia and paracesis. Multiple myeloma is a malignancy of the plasma cell. The second most common prevalent blood cancer after non-Hodgkin lymphoma. As regard myeloma Canada already 2013, that multiple myeloma is second most prevalent blood cancer after non-Hodgkin lymphoma. The condition is characterized by present myeloma cells in the bone marrow more than 10%, positive hemiclonal proteins more than 0.5 grams, and the presence of more than 1 organ damage. The criteria of your multiple myeloma to diagnose multiple myeloma: positive proteins, the presence more than plasma cells or myeloma cells, more than 10% in our bone marrow, aspiration, presence of one or more organs damage, and the picture of myeloma cells, early rapid diagnosis, early treatment, rapid diagnosis, early treatment, save the kidneys and improve outcome. If your patient take care, if you will see or you found case in your clinic, your emergency, your tertiary hospital, your oncology department, don't forget rapid diagnosis, early treatment, save the kidney, improve outcome at the end. And this CRAB, don't forget CRAB, hypercalcemia, renal failure, anemia, and bone lytic lesion, and other tests, and myeloma. Don't forget these fake symptoms, and don't miss these symptoms: fatigue, back pain, weight loss, anemia, and hypercalcemia, muscle weakness, decrease deep tender reflexes, polyuria, anorexia, nausea, vomiting, arrhythmia, heart block, short QT interval, hypertension, all these criteria for hypercalcemia, multiple myeloma, CRAB, hypercalcemia, renal impairment, anemia, bone lesion, and this bone marrow biopsy, bone marrow plasmacell more than 60% clones, and involved or an involved free light chain ratio more than 100, more than one focal lesion by the MRI, and this cytopenia as we mentioned before, and this spinal cord compression, and this multiple myeloma diagnosis again, and this also with this bone marrow expansion myeloma, with multiple myeloma, and after therapy already he started to be relapsed or decreased. Our patient received aggressive treatment in hospital. His serum creatinine normalized. He was started on the induction treatment and achieved remission. He underwent high-dose chemotherapy and autologous bone marrow transplant. He's alive and well in remission 4 years out from index presentation. Multiple myeloma key point, index suspicion, early presentation, on specific signs and symptoms. Don't forget that. Back pain, lytic bone lesion, mental status change, hypercalcemia from dehydration, from hypercalcemia, fatigue, anemia, recurrent unusual infection, pain in extremities, especially hyperviscosity, neuropathy, just from hyperviscosity, and radiculopathy, and renal insufficiency, hypertension, diabetes, don't forget comorbidity also. Multiple myeloma key point, median age around 70, more than female, male more than female, black more than white, and the CRAB, don't forget that. All patients with myeloma previously had megas already and or smoldering myeloma. Monoclonal gammopathy will progress to smoldering myeloma and then multiple myeloma. Our spectrum of disease either megas by his criteria and smoldering myeloma by his criteria and multiple myeloma. Hemoprotein less than 3 grams with megas, plasma clones or plasma cells less than 10%, no organ damage, all this criteria for megas, smoldering myeloma, hemoproteins more than 3 grams, and plasma clones more than 10, and no organ damage, this smoldering myeloma. Multiple myeloma, hemoproteins more than 3 grams, with plasma cell more than 10 grams, organ damage, all this criteria for multiple myeloma. This is the scenario we'll be having for our patient megas. Monoclonal gammopathy will be ended by megas, smoldering myeloma, and then by multiple myeloma or amyloidosis or Walden's microglobulinemia or chronic lymphocytic leukemia and non-Hodgkin lymphoma. And this again, this summarized, just you can take a picture and you can read later, with the criteria for megas as I mentioned, and smoldering myeloma and active myeloma criteria. And this is our reference if you can read more about megas and smoldering myeloma and multiple myeloma. دائما لا تنسى الصلاة والسلام على حبيبنا محمد صلى الله عليه وسلم. ودائما نسألكم الدعاء بالتوفيق والسداد، ولا تنسونا من صالح الدعاء دائما. ونلقاكم إن شاء الله في تكملة للأونكو-Nephrology presentation. I think next time I will try to cover all cases with AKI or whatever gene or chemotherapy and nephrotoxicity after chemotherapy exposure. This will take some time because Onco-Nephrology is a new grown subdivision in nephrology. دائما ونسألكم الدعاء بالتوفيق والسداد والصحة والستر والعافية والبركة في المال والأهل والأولاد. والسلام عليكم ورحمة الله وبركاته. ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ونترككم في رعاية الله وحفظه، ونلقاكم بفيديو قريب إن شاء الله. والسلام عليكم ورحمة الله وبركاته.